Audio course on intrahepatic cholestasis of pregnancy, Episode 4, Thresholds and Delivery Timing Without Memorization. This episode is based on the Israeli position paper on intrahepatic cholestasis of pregnancy, Ovadia 2019, and the SMFM consult series on ICP. The goal of this episode is to make the dry numbers memorable. The numbers in ICP are 10, 40, and 100. 10 names it, 40 changes the tempo, 100 changes the risk conversation. Let us take them one by one. 10 micromoles per liter is the diagnostic threshold most often used. If a pregnant patient has characteristic pruritus and total bile acids above 10, ICP is supported. This does not mean that a patient with bile acids of 9 and classic symptoms is impossible. It means the diagnosis is not yet biochemically confirmed. If symptoms persist, repeat testing. The number 10 belongs to diagnosis. It does not by itself mean delivery. A patient at 31 weeks with bile acids of 14 does not need immediate induction. She needs treatment for symptoms, repeat labs, risk counseling, and a plan. Now 40. 40 micromoles per liter is a management boundary. The Israeli position paper classifies mild disease up to 40 and severe disease above 40. Ovadia and earlier cohort data show that higher bile acid levels are associated with more adverse perinatal outcomes, including spontaneous preterm birth and meconium.
40 is not the same as 100, but 40 tells you that the pregnancy has moved out of the lowest risk biochemical group. It changes the tempo of follow-up and delivery planning. Now, 100. 100 micromoles per liter is the high-risk stillbirth threshold. In Ovadia's individual participant data meta-analysis, stillbirth prevalence in singleton pregnancies was about 0.13% below 40, 0.28% from 40 to 99, and 3.44% at 100 or higher. That is why 100 is not just another round number. It is the point where the fetal risk conversation changes. There is one evidence caveat residents should understand. These are observational data from pregnancies managed in real clinical systems. Many patients were delivered early, especially when clinicians were worried. That active management may have helped keep stillbirth rates low in the lower bile acid groups. So the correct interpretation is not below 100 is risk-free. The correct interpretation is the clearest stillbirth signal is at 100 or higher, and lower groups still require repeat testing and planned management. Now, let us talk about peak value. Delivery timing is based on the highest bile acid level measured, not simply the most recent value after treatment. This is explicit in the Israeli position paper, and it is consistent with Ovadia's conclusion that women should be managed according to maximum bile acid concentration. Why peak?
Because a later, lower value may reflect treatment, timing of sampling, or natural fluctuation. It does not prove that the fetus was never exposed to the higher risk category. Peak bile acids are the pregnancy's demonstrated maximum exposure. Now we move to delivery timing. Start with the local Israeli recommendation, because local practice matters. If peak bile acids are below 40 micromoles per liter, the recommended delivery window is 37 plus 0 to 38 plus 0. If peak bile acids are 40 to 99, the recommended delivery window is 36 plus 0 to 37 plus 0. If peak bile acids are above 100, the recommended delivery window is 34 plus 0 to 36 plus 0. The Israeli paper also says that delivery at 34 plus 0 to 36 plus 0 may be considered when elevated bile acids are accompanied by pruritus unresponsive to treatment, a history of fetal death at an earlier gestational age in the presence of cholestasis, or departmental discretion. Now compare SMFM. SMFM recommends delivery between 36 plus 0 and 39 plus 0 for ICP with total bile acids below 100. Within that group, values below 40 fit the later end, and values 40 to 99 fit earlier delivery. For total bile acids at or above 100, SMFM recommends offering delivery at 36 plus 0.
because the risk of stillbirth increases substantially around this gestational age.
SMFM reserves delivery between 34 and 36 weeks for selected patients with bile acids at or above 100, plus additional high-risk features. Those features include excruciating and unremitting pruritus, not relieved by medication, a prior stillbirth before 36 weeks due to ICP with recurrent ICP in the current pregnancy, or pre-existing or acute hepatic disease with worsening function. So how should the resident reconcile this? Do not pretend the guidelines are identical. They are not. The Israeli guidance is more aggressive for the above 100 group, allowing 34 to 36 weeks. SMFM generally defaults to 36 plus 0 unless additional high-risk features exist. But they share the same skeleton. Bile acids below 40 are the lower risk group. Bile acids 40 to 99 move delivery earlier. Bile acids 100 or higher are the high-risk group. The difference is how aggressively each system balances prematurity against stillbirth risk. Now, let us make this practical with scenarios. Scenario 1, 32 weeks, severe itching, bile acids 18, mild ALT elevation. This is ICP, but it is not a delivery diagnosis at 32 weeks. Start ursodiol, repeat bile acids and transaminases, counsel, follow in a high-risk framework, and plan delivery according to later peak values. Scenario 2, 35 plus 3, bile acids 52. This is the 40 to 99 group. Under Israeli guidance, delivery is planned 36 plus 0 to 37 plus 0. SMFM would also move toward the earlier part of the 36 to 39 range. This is where corticosteroids may matter if delivery is expected before 37 weeks and they have not already been given. Scenario 3, 35 plus 1, bile acids 120. This is the high-risk group. Under Israeli guidance, delivery from 34 to 36 weeks is recommended. Under SMFM, offer delivery at 36 plus 0, but consider 34 to 36 if there is unremitting pruritus, prior early ICP stillbirth, or worsening hepatic disease. In real practice, this patient belongs in MFM level discussion, with explicit counseling about prematurity and fetal risk. Scenario 4, 37 plus 2, classic pruritus, no rash, prior ICP, ALT elevated, bile acids pending. Here, diagnostic certainty is incomplete, but gestational age is early term. SMFM allows shared decision-making in early-term suspected ICP when bile acids are pending, especially if transaminases are elevated or there is prior ICP. The Israeli paper says term delivery may be considered in high clinical suspicion without bile acid testing. The key is shared decision-making, not pretending certainty. Scenario 5, 35 weeks, itching, but bile acids normal and no repeat confirmation. SMFM recommends against preterm delivery before 37 weeks for clinical ICP without laboratory confirmation of elevated bile acids. That is an important safety rule. Treat symptoms if needed, repeat testing, and keep looking, but do not create iatrogenic prematurity without biochemical evidence. Now let us talk about the emotional side of thresholds. Patients and clinicians often want one number that says, induce now. ICP does not work that way. Bile acids create a risk category. Gestational age determines what you can do with that risk. A bile acid of 105 at 34 weeks is not the same operational problem as 105 at 37 weeks. The decision is always a balance. On one side is fetal exposure to high bile acids and the possibility of sudden fetal death. On the other side is prematurity, respiratory morbidity, neonatal intensive care, and long-term effects of early birth. Delivery timing is where those two risks are forced into the same room. Now, final synthesis. First, 10 diagnoses. In a symptomatic patient, bile acids above 10 micromoles per liter support ICP.
Second, 40 changes the tempo. It marks a higher risk management group and moves delivery earlier. Third, 100 changes the danger category. It is the key stillbirth risk threshold from Ovadia 2019. Fourth, below 100 is not the same as no risk. It means lower risk under active clinical management with repeat testing and planned delivery.
Fifth, use peak bile acids. Do not let a later treated value erase the highest exposure category. Sixth, local Israeli guidance and SMFM differ in exact timing above 100, but they agree on the central biology of risk stratification. 10 names it. 40 moves it earlier. 100 changes the risk conversation. End of episode 4.